Evening, friends. Welcome to the Indian Arthroscopy, Basic Arthroscopy teaching course. We have Dr. Nishith Shah, a very senior and renowned arthroscopy teacher of our country, and he's got an extensive experience in PCL reconstruction surgery. We have been listening to amazing surgeries, procedures of PCL, which he has been doing for so many years. And if I am not wrong, he's one of the pioneers in PCL reconstruction in India. And he has taught so many people to start and doing PCL surgery. So we are lucky that Dr. Nishith Shah has agreed to be as a faculty on this basic arthroscopy education platform to teach us the very basics of PCL reconstruction. We are also joined by Dr. Vishal Kasliwal and Dr. Abhijit Savadar. Both are young, dynamic arthroscopy surgeons, extensive experience in knee arthroscopy. They are going to be panelists for this session. They are going to initiate discussions, get into question answer sessions with Dr. Nishith Shah, and I think make our program more lively. Thank you, Samanta. Thank you, Bhupesh Karthik, for joining in as well. We have Dr. Mukesh Chugh, Dr. Tejas on the panel as well, will help in asking questions directly to Dr. Nishith Shah. So all yours, sir. You can start your talk. It is an informal plan, so we will probably stop you in between, ask you some questions, and then proceed. So hope you are okay with all this, sir.
Yeah.
Yes, Nishith bhai, this is a real honor from the IAS that you have agreed to come around and teach about the and I know this is PCL is your passion, and probably now in our country, he is the only guy who has done maximum pediatric PCL surgery. I have discussed many a times the tricks. I have learned many things about the PCL from his, and he is one of the way my guru in the knee arthroscopy and whatever arthroscopy we have learned nowadays, because in many meetings he was the faculty, I was a delegate. So again, today I am the delegate, he is the faculty.
तुमने मुझे रुला दिया boss.
Chalo, okay. And I also welcome Vikram and also Abhijit and all our EC committee members and all the other panelists here. So it's all yours, Nishith bhai. You can go ahead.
Okay. Are you able to see my screen?
Yes, sir. Yes, sir. We can see that. You can go ahead.
Okay. First of all, thanks to my old buddies, IPS and Samanta, who has given me this platform. As you said, that it is my passion, because it is just becoming popular, but somehow I don't know how, because I went with Strobel. Very early I became interested into this, and I could see that this is a problem of this country, because in this country everybody sits on the ground, and 90% of the Indian population uses Indian type of toilet where they need full flexion of the knee joint. And when you have PCL injury, then it's the starting of the arthritis. That is we are going to discuss. We all know that it is a two bundle, and the PCL is much more stronger than ACL, and you have ligament of Humphrey and ligament of Weisberg, which is meniscofemoral ligaments. We do not know how much they are contributing, but now we have realized that they are not the vestigial structures, and we should try to preserve it as much as possible. And the tibial attachment of the PCL is 1.5 centimeter below the joint line, and that is an important thing when we think about the tibial bony avulsion. Okay, that we are going to discuss afterwards. And it has a very large attachment in the femoral intercondylar notch, which is 13 to 15 millimeter wide, and that is why many of the orthopedic surgeons who are doing PCL, they like to do a double bundle PCL, because with a single bundle it is very difficult to give such a wide attachment to a PCL. But over the period of years, now we are having a preservation or augmentation of the PCL. We do not remove the PCL, and I think that has made huge difference in the outcome of this PCL reconstruction surgery. Both the bundles, they behave differently in flexion and extension. The anterolateral bundle, which is more stronger and more larger, is tight in flexion, and when you think that this is the bundle which is more involved in any injury of the PCL. That is why the anterior drawer is or the Lachman is positive when in 90-degree flexion and not in extension. And that is why we always say that when the PCL is there, you have to do uh, uh, anterior drawer in 90-degree flexion, because that makes the anterolateral bundle, even damage anterolateral bundle loose. So why if it, अरे हिमानी बंद करने यार, तू શું કરે છે, મારી લેક્ચર ચાલુ છે यार. Sorry. So why we are missing the PCL injury for so many years? And first and foremost thing, I feel that we do not take proper history. Either we have too much of work, or we have very fixed ideas about taking, because the PCL unnecessarily to acute cases, which is around 15% or 10% of my total cases of PCL reconstruction, PCL injury. All other patients are coming out after 6 weeks, 8 weeks, 12 weeks, 3 months, 6 months. So they are all chronic patients. So, and why am I able to see more PCL? Because I spend time with the patient, and I always ask them about their injury, previous injury before 3, 4, 5 years. And you will be surprised that if you do this, then how many patients they will come and tell you, हाँ sir, एक बार मैं गिर गया था. It means like they do not remember that it had any relevance with the current situation, but that is what happens. And we know that there is no pop sound like ACL injury. There is no pain in the initial stages of isolated PCL injury. So that is why usually the diagnosis is not so fast as ACL injury. And people, they do not have unstable knee unless there is a multiple ligament injured knee, and gradually they develop problem in their activities of daily life. So they are able to lead the life for few years, and that is why the PCL is not diagnosed. And when we do arthroscopy, we see sloppy ACL because of the PCL, and that is what the is mistaken for ACL injury. And if these patients underwent or undergo an ACL reconstruction, then I think it is a catastrophe, and we must avoid it by doing proper. And this is what the ACL injury in India is. This is the flexion injury, hyperextension injury in my city, in the city area where the stairs are at the 45-degree slope. So there is a hyperextension injury, and this is the Indian dashboard injury because of two-wheeler accident. 38% patient in acute hemarthrosis has a PCL injury of various grade. So whenever you aspirate a joint and you see blood in the initial stages or a fluid, you must understand that you might be missing a PCL injury, or you might be seeing a PCL injury. So once you have aspirated, please examine the patient again, because now the hemarthrosis is gone and the joint has become relaxed, and you might be able to get a better understanding of the ligament injury. Isolated PCL injury is very less than 4% as compared to, but when PCL is injured, then almost 95% of the other there are 95% chances of other ligament getting injury. So when you have diagnosis PCL injury, you must understand that isolated PCL injury is very less. So you have to search for other ligament and other pathology. And this was done before almost 20 years, and it has still remained the same. So I'm sure that we must understand that we have to be critically evaluating patients when we see a patient with hemarthrosis or swelling of the knee joint after an injury. So why we are not getting uh, drawers or Lachman positive in the initial stages? And if you turn the patient and look at the popliteal fossa, you will be able to see such hematoma. And this is the hematoma which works as an internal splint, and that is it you can a space occupying lesion. and because it is pressing on the capsule and other structures, it does not allow you to do a proper test, either Drawer's test, or unless until you do the test under anesthesia. And once this hematoma is absorbed, then this patient will have a positive Drawers for PCL or Lachman test. So please, if you do this and if you are not getting a, a positive test, please call the patient after few days and see that you examine the patient again and you don't miss a ligament injury. This is what, when the PCL and the ACLs are intact, there is a normal alignment of the joint. We know that the patellar tendon is the one of the strongest tendons in the human body, and it cannot stretch, right? So when the PCL is not there, the tibia subluxes backwards, and that is why the patella, because now the patellar tendon cannot stretch, the patella abuts with the femur all the time in all the positions, especially after 90-degree, because that is the time uh, there is a maximum pressure of the uh, and and that is why the patient develop patellofemoral with a constant subluxation, because the anterior tibia is medial anterior tibia abuts with the anterior and posterior part of the femoral condyle, and that is why you have medial femoral condyle arthritis changes and medial meniscus tear. So when a patient comes with anterior knee pain, don't only treat it as a chondromalacia patelli. When the patient comes with the anterior knee pain, the one thing must come to your mind is that this patient might have a PCL injury, and if you miss it, then his chondromalacia is never going to be all right in any time. So when you see unresolved anterior knee pain, there might be a PCL injury, and the patient says that, sir, सुबह Indian toilet में बहुत दर्द होता है, then there might be a PCL injury also if the patient doesn't have unstable painful knee. The problem is that a person like you and me who are sitting in the chair, you are not using Indian toilet, will have developed these symptoms after a few years. The persons who are every day doing some household work, who are sitting on the ground, they might develop the symptoms of PCL deficiency earlier. So there is no definite pattern that who are going to develop. Only thing is that the chronic, when I tell everybody that if the patient comes to me after 3 or 4 months of his injury or afterwards, then that patient is symptomatic, and I have to find that why that patient is symptomatic, and that is what we should do. I don't think we need to learn lot of tests for any ligament injury of the knee. If you need 4 or 5 tests properly, then 95% of the ligament injuries of the knee you can see. That the same thing is applied to PCL injury diagnosis. The Drawers test, the Lachman test, we know, and one has with the practice only. And I am sure that everybody now who is doing good work, a lot of work, they know that what is the endpoint, whether it is a soft anterior endpoint or a soft posterior endpoint of the PCL injury. So we have to identify the soft endpoint for PCL and or the ACL. For me, the step-up test of the Harner is very, very accurate, even to diagnose the gradation of the injury, grade 1, grade 2, grade 3. And that is what I rely on it. For this, you have to put your finger on the upper part of the tibia, and you will always see that there is a 1 centimeter like posterior step off. The tibia is anterior and the femur is posterior, and when the PCL is not there, it slides backwards. So that is why your step off becomes small, and according to that, along with other tests, you will be able to clinically diagnose that how the PCL is, how much is the PCL is injured. Of course, pivot shift everybody does to differentiate other ligament injury, and the dial test is very useful when you have you suspect it the lateral injury, and whether it is ACL or PCL. But dial test will give a idea about the posterior corner. So these are the 5 tests that is I do. Of course, there are many tests they are maintained, uh, but these are usually not required in day-to-day practice. And this is what I feel that this will be able to diagnose most of ligament injury along with the valgus and varus test.
Sir, two, 3 questions if we can just maybe pause for some time.
Boli.
So one symptom you said for a chronic PCL is patellar chondromalacia. So if the patient comes with patellar chondromalacia, you suspect that there might be an old PCL injury. Any other symptoms which young people can look out and then start to clinically examine PCL, like climbing stairs, recurrent effusions, or any other symptom?
The thing is, what I have found out is there are 3 things. One thing is if they sit cross-legged,
okay,
whether on the ground or whether on the cot, because now the when we sit cross-legged, the medial condyle is overloaded. And that is why they will get a pain within 10-15 minutes depending on the laxity on the medial side of the joint. So what they do is that they open up the joint 2-3 times, they make it straight, and they again. So most of them, unless until you ask them, they are not even aware about this, that this is happening to It's so easy. It's so easy. They sit on the ground, they have the knee pain in cross-legged sitting position. They open up the knee. Again, they put it for 10-15 minutes.
So that's another symptom.
That is another thing. Stair climbing,
climbing down, climbing upstairs.
I am not able to identify that which bundle is climbing up and which bundle is climbing down. But one thing is very certain, that most of the patients have pain in climbing down because naturally the tibia is subluxating backwards, and that is why their patella is overloaded and they have the problem in stair climbing. So these are the few symptoms. And as a patient will tell you that, sir, I can walk 5 kilometers on the even ground, but when it comes to slope, or if they have to go to temple every day, which is on the height, then they are not comfortable. So these are the symptoms that patients they tell us when there is a PCL injury. Instability, as I told you, that unstable knee, then it has to be either medial or lateral ligament injury along with PCL.
And any incidence of recurrent effusions do you find, or it is not seen commonly in PCL?
No. This is recurrent diffusions. I have seen more in children because they are very active. So when I see PCL in children, most of them, they do not come acutely. Most of them, they come very late, and their father will say कि सर थोड़े दिन होता है ना उसका पाँव में फूल जाता है. And that even the teacher in the school, they tell them that भाई ये खेलने जाता है ना तो उसको मजा नहीं आता है. So effusion, and I have a patient who had 100 times aspiration.
And it was a PCL tear, basically.
Not PCL, both ACL and PCL both. Okay. And it has been 5 years, and now there is no effusion.
So another question which is there in clinical examination: how sensitive is a quadriceps active test to diagnose a PCL?
Quadriceps active test is is first thing that the patient is find is very difficult to do it.
Yeah, relax.
I do not think that any acute condition any patient will be able to show you. This is a good case for chronic cases where, so sometimes the patient will sit in your chair, and he will just show you, okay, sir, ye mera paam aise hota hai, But those are the rare things, and I think the other tests are so simply to be done that if the patient demonstrates, I am very happy that there is an additional diagnosis. But I will not depend on because it shows me not only one ligament, it shows me that there is more than one ligament when such a quadriceps active test is demonstrated by the patient.
Abhijit, Vishal, Bhupesh, anything you want to add or ask questions with Dr. Nishith, sir? Yeah, Vishal, unmute yourself and initiate.
So by the end of your clinical examination in history, how does your clinical examination aid you in decision whether it's going to be conservative or it's going to be...
First, sorry. Tell me, can you speak again?
Yes, sir. So by the time we finish the history and clinical examination, especially the clinical examination part in PCL injuries, would you have made up your mind to some extent, like which way this case is going? Is going to go conservative? Is going to go operative? Some things which aid in your decision making at that point of time. Any tips and tricks over there, sir?
See, for me, any injury that comes after 3 to 4 weeks, and I see PCL injury, it is a chronic case for me. Active individual or very young guy showing me grade 2, grade 3 PCL injury after 3 or 4 weeks, I will not ask him to have any conservative treatment. Only thing that if it is an acute case, who comes in 2, 3 or 4 days of the injury, then definitely I'm going to tell him about the conservative management, and that is I'm going to talk that what a conservative management that usually I give to the patient. So after 4 or 6 weeks, for the either with the PCL grade 2, grade 3, or PCL grade 2 with lateral or medial, that patient, an active patient, for me, conservative management I don't do.
So
What is other of IPS? What do you think?
You're right, sir, but acute is different and chronic is different.
Yeah.
So you said your chronic is 4 weeks, sir.
Yeah, from 4 to 6 weeks max.
Max. Okay. And do you give a trial of a PTS brace and see the patient is improving, especially in grade 2 or a grade 3? And if he is improving, then probably PCL would help. Is bracing, a trial of bracing helps you in making diagnosis?
If you read a lot of papers,
Mm-hmm.
all these papers who are done this, the patients are symptomatic, and these patients have come from the Western countries where patients are not sitting on the ground. Patients are not using their knee in Indian toilets. Okay, our culture is very different, boss. So उनका पेशेंट चला लेता है क्योंकि उसको हर रोज उसको यूज नहीं करना है अपने पेशेंट को एवरीडे.
So for you the threshold is low. I mean, you would like to operate and make them normal.
I have seen so many problems with the chronic PCL injuries and patient coming after 1 year, 1.5 years, where few of them had to land up in osteotomy. Because they are very heavy weight लेते हैं, and they are a very heavy worker. The fabricators, the person who is working as a fabricator, the tire जो बनाता है वो, ये लोग को हर रोज नीचे बैठना पड़ता है. They are lifting very heavy weight, so their PCL deficient knee doesn't behave in the way that we want them to behave.
Okay.
Conservatively.
Sir, can I just add one point, sir?
Yeah.
For people who are working in high trauma centers, because PCL injury is one of the most commonly missed injury. Anybody who's seeing a knee injury with anterior aberration, they should think of PCL.
Absolutely.
Anyone who has an anterior aberration, definitely they should think of PCL and do a good lateral view to rule out avulsion fracture. I think that's very important.
Not even I would feel that if you give a conservative and the patient doesn't become. I have seen a girl today where I have given her a conservative management, and she is 34. The PCL is not healed, boss. I don't know why. We have given her a PTS brace, everything we did everything. I do not know why it does not. But she also has a ankle grade 3 injury of the deltoid ligament. So I don't know whether the same limb, So I don't know whether the ankle is painful, is contributing to the knee problem or not. But this is what I have marked today.
I think this has been told by Nishith bhai repeatedly that even if in chronic case, if you see that there is a heel scar sign on the front of your knee, first your eyebrows should be like that. Probably I'm not going to miss the PCL. Even a heel scar for 4 or 5 years, chronic scar, any black scar in the front of the knee is probably your PCL. You have to test twice.
Correct. Yeah. Correct. I think that's a very important.
So I think Nishith bhai, you can go ahead.
Okay. So and we do not need to we do not need to have all the time the MRI. Okay, and but the problem is that now the MRI has become so much common that people are not ready to accept. And you and me and everybody knows about the MRI reports as far as the PCL injury is concerned, and especially the PCL if it's with the PLC. Okay, so these are the stress use that my radiologist does, and you can very easily do even the stress use in your clinic by 90-degree flexion and putting the giving the telling the patient to give the thrust from up to down, and you can do this. And if you see so much of subluxation, then you must think that this is the more than 10 millimeter and this is the grade 3 injury. And I don't think that this patient, if it's a chronic patient, there is any role of conservative management, at least for me. CT scan, yes, very useful in certain cases, especially when you have tibial flat or fracture with PCL injury, as you can see here, because that will help you to plan your surgery. And of course, tibial avulsion of the PCL, uh, most of the time you will be able to diagnose with only with X-ray, and you don't need to have a CT scan. But if you get it done, then you might not miss small other fractures. MRI, people say is a 95 to 100% accurate in certain cuts. Normally, it is a comma shaped as we see in the. So when you see a straight PCL, it should alarm you that this is a stretched PCL. Of course, the ends are normal, but it is like a overstretched elastic of your underwear, where the elastic is intact, but it is not functioning. So this is what I think. This is a 12 years old boy, and this was his PCL which was stretched, and this was unfortunately in India we are not able to compare both the sides. Otherwise, I would love to do that on the both the sides of the same cuts. 3 millimeter cuts, and I usually ask them to give me 3 millimeter cuts or for the PCL injury or the ligament injury, and if they don't give it, I send the patient back to them. So you must insist about 3 millimeter cuts for to diagnose PCL injury. And this is it can also give us a location of the tear, that is whether it is a mesh substance or femoral or tibial. As I told you, there is a stretched ligament associated injury, and but I will always take it with a pinch of salt. I will always rely on my clinical examination and then correlate the MRI finding, and that is what the advantage is for us. Long-standing chronic PCL injury with medial compartment arthritis, and if the patient is complaining of medial pain afterward, don't, even if the patient is young, and if the injury was like 1 year and 1.5 years and the patient cannot walk more than 500 meters, then I will always get a full length X-ray scanogram, what we call as the HK X-ray, and you can take a patella view by comparing both the patella. And as the PCL is deficient, the tibia is subluxated backwards, and the anterior femur always rub with the tibia, and that is why the patient and that is on the medial compartment, and that is why we see half of the tibial articular cartilage damage when we do a chronically PCL injured knee with femoral articular cartilage damage, medial meniscus injury, and half of the typical osteoarthritic changes, but osteoarthritic changes in a very young patients. So friends, conservative management, if I cannot diagnose, as I said, that there is acute injury, hematoma, and then I would ask the patient to do under anesthesia, which takes me 5 minutes. And most of the patients are ready if I am not given to diagnose, but the number is very small. Aspiration must be done, as we discussed before, that aspiration is important, not only to know that whether there are other ligaments are injured or not, but it prevents the quadriceps inhibition, and patients are able to do better exercise after your aspiration. Isolated PCL injury, definitely the chances of healing is very, very high. So you have to give PCL brace or what PTS brace, whatever the brace you call it, with a posterior side support. And if the patient is unreliable, then I usually I do is I incorporate into the plaster the pad. I keep around 8-10 pair ready in my clinic. So whenever the patient comes, even in the if most of the patients, they come with a normal brace, so you can just put this and ask the patient that put this pad inside your brace existing. And basically you want to prevent the posterior subluxation of the tibia for around 4 to 6 weeks in these patients. And that is what the time is for healing. And weight bearing, yes, immediate weight bearing. If it is isolated PCL injury, either a patient can take a stick or a walker for a few days, and then and I insist for SLR and ankle pumps and other exercises. That is a very important part of my conservative therapy. And usually after 3 to 4 weeks, we remove the plaster, and then we start knee bending and other exercises for this patient. And usually these patients are not allowed to sit on the ground or sitting cross-legged or squat for at least 2.5 to 3 months. Bony avulsion of PCL, tibial avulsion, and we must understand that the PCL is 1.5 centimeter below the joint line. So if you see the fragment at the joint line, means it is displaced by 1.5 centimeter or 1 centimeter, and that is not going to go back. So you have to fix this fragment, otherwise this patient is going to develop a chronic PCL laxity, and the PCL that we were going to save, you will have to sacrifice and do a reconstruction surgery. So like this patient, if you do not carefully see and if you are not clinically examine this patient, you are going to miss that this patient has a tibial avulsion of the PCL, as you can see here. And this needs fixation because this is like an open book. And even if you give a conservative trial, probably if you are not able to follow up the patient after, say, within 2 weeks or something, then probably this open book is going to displace, and patient will come with a displaced fragment. So even if this such an open book fragment in a young individual, I feel that either you do open by screw, or you could do arthroscopic spool out sutures that we do like this, put the jig inside the intercondylar notch.
So we'll pause for a moment. There are some questions here. Tejas, you can unmute and ask question directly to sir about your conservative therapy. Tejas.
Yes. Sir, I have a question to you. 2-3 questions regarding conservative management. First question is, when the PTS or the special PCL brace is not available, so can we put a pad over the long knee brace and use it?
Absolutely. You should be around 1 inch.
Okay.
What you can do is, in my theater, when sometimes when I'm doing surgery, of course I have got a ready-made pads available. But sometimes what happens that if there is not a pad available, then what you can do is that you can fold the towels and put inside when you are bringing a theater patient out of the theater, and then you manage for the pad. Basically you prevent posterior subluxation of tibia either post-operatively or for conservative management.
Okay, sir. So second question is regarding the PCL avulsion. Sometimes there is a avulsion of the PCL with comminuted fracture fragments over the distal part of the PCL. So, and when we see the MRI in the sagittal cuts, we see the straight PCL with almost no displacement of that comminuted fragment. So, can we conserve it, or when I think when we conserve the PCL avulsion?
See, when you conserve the PCL, when you clinically examine, and there is only one grade 1 laxity or something, as compared to opposite side, and for that you have to make this patient pain free. If the patient is having pain, then the muscles are in spasm. Sorry, and muscles are in spasm, and you are not going to get a correct view of your ligament laxity. So And as I told you that if the patient, you are not able to follow the patient immediately after, let's say, 1 week, 10 days, 15 days, then it is better to err on on the side of fixation. And when you have comminuted fraction fragments where you cannot put a screw or something, then this is a technique that what the pull-out wires that I have been using. I do not do any screws in the PCL. I usually use this pull-out technique for all my PCL avulsions, tibial avulsions.
The last question regarding the PCL avulsion. Sometimes the PCL avulsion which is neglected and come to us with the 4, 5, 6 months. I have one patient with the 8 months old PCL avulsion. So with a good chunk of the bone. So in that case of the neglected PCL avulsion, should we do the fixation or straightforward the reconstruction is best?
I don't think because I think that PCL is already contracted. You know, the thing is that PCL being an extra synovial ligament, it doesn't become very rounded or it doesn't become contracted like ACL. But the I think at 8 months you will not be able to bring it down. And if you want to do it something, then I would do definitely open fixation, because then and then you will be able to understand that whether you are are you able to bring it to the crater or not. If you are not going to bring it to crater, then it is better to exercise that and do PCL reconstruction.
Okay, sir. If we decide to reconstruct the PCL in that case of the neglected PCL avulsion fracture, can we reconstruct straightforward and remain that PCL at that place only, the avulsed PCL original?
No, so I think I would at least take away the bony part, you know, if it is large chunk of bone, because it is going to rub when with the PCL the new graft, you know, and it will it will abrade the graft. So I would like to remove the big chunk of bone. If there is a comminuted fragment, small ones, then there is not a problem because they are already covered with fibrosis.
Okay.
So that is what usually I do it. But chronic PCL, what I have done is usually PCL reconstruction. If I see avulsion, it is not coming down, and this will usually what I do is that when a patient comes with a PCL avulsion in acute case, I do a flexion extension view of
Okay.
lateral,
Okay.
and it will show you very nice displacement. You know, if it is that displaced, then you have to fix it.
Okay.
But if you see this chronic patient and if you do a lateral flexion extension view, the PCL chunk remains at the one place only. It doesn't move. So so I think we should do a PCL reconstruction in these cases.
Sir, what is your time limit to do a PCL avulsion fixation? Like,
Around I think around up to 3 months you can pull it down.
okay, sir.
Around 3 months you are able to pull it down.
Nishith sir, most of the time when we do an arthroscopy in a PCL deficient knee,
yeah,
you are actually able to see PCL intact. You are diagnosed by pseudo laxity of the ACL.
Yes.
And you are unable to identify the tear, physical tear which is there in the PCL, which when in ACL we always physically demonstrate a tear. So why does PCL tear is not visible to us? Is it covered with synovium? It heals in elongation?
Yeah, because PCL has a very high blood supply from the popliteal area. It tends to heal. But you know the laxity remains because there is an intrasubstance laxity, and that is why you know the sloppy PCL or a sloppy ACL sign we are able to identify or we are able to appreciate. But and most of the time what I have marked is also one thing, that if you pull the PCL 3, 4, 5 times, then suddenly it starts becoming loose, you know.
Okay.
हाँ, वो शुरुआत में लूज नहीं होता है, मगर तुम तीन चार बार एंटीरियर ड्रॉवर देके तुम्हारा असिस्ट को बोलोगे और फिर खींचोगे तो धीरे धीरे वो because it has a lot of fibrosis, because a long ligament it has a fibrosis, and that is why you know then it becomes, and if you do not give anterior drawer while examining the PCL, then it is, of course, it is not going to be it is
visible.
Always going to be tight for you.
Sir, to add to Dr. Tejas's question, if they have initially I was also using this Gamgee pad and ortho roller pad for posterior support with a regular knee brace.
Right.
But they usually don't work because they displace. With sweat, they become small and dirty.
Yeah.
If you do an ortho test, this was taught to me by Abhay Narvekar, sir. They can just put a Velcro and give a small cushioned wedge there. 100 rupees, 150 rupees, it can be put on to the regular knee brace.
Yes.
That is one option. The other thing that I've started doing now is the regular school dusters that we have now, the sponge dusters.
Right.
I make them buy 5 or 10 dusters to start with, and I pad 4 dusters on the lower half of this one. Fix it with just Fevikwik. And when they come for first review, if it is compressed already, I remove it with a blade and then keep another 2 new dusters and then keep it. Not the duster with a metal back, the sponge dusters.
Only the smooth part, I mean the part that rubs.
Not the wooden duster, not the wooden duster. The olden days we had the duster, no? There's the sponge, rectangular sponge duster.
Okay.
So 4 dusters, 4 rectangular sponge dusters.
Okay.
Fit very well in the lower half of the knee brace.
Okay.
Quick, which is available for 5 rupees. The duster is another 5 rupees. You can keep it and make your own PCL brace.
So how many times you change it?
Sir, I change it every time I see them because it is not very costly. Fevikwik is 5
I understand,
rupees.
but how much?
I usually use them for post-operatively for 1 month or maybe 6 weeks.
Okay.
So when they come for the 10th day or 12th day suture removal, I change it once. And usually with that it is done.
You should send me the pictures of this.
Yeah.
Okay.
Yeah. Vishal has a question. Yeah, Vishal.
When I started my practice, I came from Pune and to Nasik. So Pune PTS was readily available. So I showed one of those PTSs to my orthotics guy, and our regular long knee brace, he created a pad. The regular orthotic guys are able to create those pads and stick it with counter Velcros and very easily create this PTS. So the cost of the original PTS was very high, and he bought it to near 1,000 rupees or less. So correct. Even if you just tell your local orthotic guy wants to prepare it,
orthotics can do it fantastic
in the city.
Abhijit, you also wanted to say something? Yeah, Abhijit, unmute yourself, please.
Okay.
So, Nishith sir, in case
bolo.
of PCL avulsion, what are your criteria to decide about your fixation technique? Whether you want to go with the screw fixation or a pull-out suture?
See, previously I used to do tension band wiring. Okay, because I used to do ACL tension band wiring. So I was very used to do a tension band wiring in ACL. So initially I used to do tension band wiring in PCL also. I have never done arthroscopic screw fixation because I do not have any experience of it, and to me to put a pin in the post-popliteal region and then retract the posterior capsule and then put a screw arthroscopically, I have not seen or I have not experienced it, so I am very much afraid about it. So now all the techniques that what I am showing you now, that is what my technique is. There is a pull-out suture. Put the sutures in the PCL stump and pull it back, through the tibial tunnel and tie it anteriorly. And that has worked very well.
In case of
screw is usually by a mini open technique. I think nobody puts screw arthroscopically for a PCL.
I know the people have shown it. I have seen the videos of it. I don't know.
Samanta, are you aware of arthroscopic?
I tell you very honestly, when the PCL is levels, the bone below is I think it has a lot of bone bruising.
Yeah.
So unless until you put a long screw, the purchase of the screw of that fragment is less, and second thing that sometimes there is a hidden
narrow edema sort of thing.
There will be hidden pieces, so you will tighten the screws and the piece becomes loose, and you might get this problem. So I think that this pull-out suture technique works very well in my hand, and that is what I usually prefer nowadays.
As IPS was asking for whether this screw can be given by arthroscopic technique, I have never seen those. I have never been recommended by most of the guys, those who are doing the PCLs in big numbers. So I have never been thought of that.
Yeah, but that is what I saw in the video.
I think if it is a big PCL chunk, it is better to use the present probe, make it a safety incision, give a screw proper size, and this is a very easy operation. Why to struggle with all these fancy things? There is no point in struggling with the fancy things.
Absolutely. Or abhi to nahi was as your age advances, you don't want to do anything which is fancy, you know.
I think pull-out sutures is good for comminuted.
Yeah, pull-out is very good for comminuted fragment, you know.
So IPS sir, is there any cutoff of the fragment size where beyond which you go for the screw fixation?
Not exactly, but I think as Dr. Nishith has rightly said, sometimes you think it is single piece, but it is more than one piece. And the size, and as you start putting screw, you would realize that that piece would break. So I think pull-out sutures are very good, or you can use something like an pull-out sutures for me is a good one. Unless it is a single big fragment which is enough to take a screw, which has to be at least 1.5 centimeters.
I think Abhijit, there should be, as because Nishith Bhai and IPS and all the senior people are talking, we should give a message to the juniors like whenever you are dealing with the PCL fragment like avulsion, you take it like one piece, single, whatever. Both the armamentarians should be ready. You should be learning both the techniques, so that if you find that during the screw tightening, it is not holding the screw properly, or the fragment is going to be crushed because of the time you use the washer that is not holding properly. So there is no point just keep it loose because it will come out. So it's better to just give 2-3 figure-of-8 sutures and make 2 drill holes, try in the front by just flexing the knee and whatever, just making it bit rotated. It's a very easy technique and safely can be done.
Samandu, I have always IPS. You can also give it the, you know, will it not strangulate the graft? What the technique was shown by apna Dinshaw, कि वो multiple sutures, you put multiple knots in the base and then you pull it down.
Yes, the thing is that Nishith Bhai, most of the people, those who are doing the comminuted fragment arthroscopically, they are putting multiple knots over there and pulling the fiber wire in the front. But
are you
it is chances there it can strangulate because at least you have to put 2 knots on that and 2 suture threads.
Minimum 2 knots, you know.
Yes. So this is the way. Otherwise, you cannot pull it down.
Right.
IPS, Nishith Bhai, have you ever heard of something putting on the top of that knot so that it can pull the fragment? IPS, have you heard of that?
Yes.
Yeah. So you can put the knot and then the comes down.
Some sort of button sort of thing so that you can pull it down in the front.
But at least 6-7 knots, you know, of the or Ethibon 5 number. So it becomes slightly longer and then it pulls the fragment down. I do not understand.
The other thing is it gives a good buttress. It gives a good buttress when you put a lot of knots, 5 or 6 knots. It becomes bulky and it gives a good buttress effect, which gives good compression of the fragment also.
But we should not tie the knots very tightly. They should be loose knots because they are just tying as a buttress. And then when you pull you down, then probably it sits nicely.
Yes.
I understand, but IPS, when we are doing this, it is very difficult to control ke bhi tum loose knot rakho.
I know, sir. But you should not over at least not over down. But I am aware of some surgeons who have used like Arthrex has got an button, 2 buttons for ACL avulsion. For an ACL avulsion, they have 2 buttons. So I think something like that can be used for PCL as well.
Yeah, absolutely.
You but can flip the button and then maybe because
some people are still recommending that you can put one button on the back side so that it holds the comminuted fragment in a proper way. There is no strangulation by many sutures. So that can be done the other way.
Yeah. So let us see your technique, sir. If you're
right.
Yes, go ahead.
Yeah. So this is what you do is that you go between the ACL and PCL. We create the window and put your PCL jig down below. You can use IITV to see whether you are gone at the proper place, and you can see that it is below, and then you pass a pin from the front, and you pass a wire loop and keep the wire loop in the popliteal fossa, or slightly bring it out, and then you take a central approach, put the cannula, and you take any device that can put multiple sutures with the help of PDS. And I usually use two different colors, white and blue, or any two different colors. You put multiple sutures through both. It is not, if I say that I put one in the anterolateral and what and the posteromedial bundle, it is not that. It is usually it is overlapping, but whatever it is, you can do this, put a multiple sutures, and then you bring that up through the cannula. You bring the crochet hook and pull the wire, and with that pull all the sutures out through the cannula, and then pull it back, and then you can see that the PCL becomes tight. And this is what and then you can put any button, simple button, titanium, on the front of the tibia, and this is what you do this PCL eversion pull out suture technique. So this is easy, and it doesn't, you don't have to even take a posteromedial or posterolateral approach, and it's a I do take a posteromedial approach, because if it's a chronic case, like 2.5 months, I want to remove the fibrosis in between the fragment and the parent bone, and that is what I do. And then I also try to put one or two uh, uh, holes to the drill bit in that area with a PCL jig, and then I do this pull out suture technique in the chronic injury of the avulsion injury of the tibia. And this is what within 1 month, this is a 1 month post-operative, and this patient, of course, it had been now 6 years, and I have not seen him again. I'm sure that, and you can see this was the anterior injury. You can see very nicely the anterior heel scar, and that's what this was, this injury and the initial stages. So whenever you see scar, as Swarnendu says, that whenever you see this scar, it should ring a bell in your mind that you might be having a PCL injury.
Just one question, Nishith bhai, just for my clarification.
Yeah.
When you take the bites in your the PCL, the stump, you take the bite from the front, or you don't even create the posteromedial portal even?
No, in the initial, in the acute stage, I do not even do a posteromedial portal.
How you take the bites then?
No, bites are from the front, no. The bites
you just take
the bites are from the, you put you put the see, this is what a spectrum is, right? So you put the bite
spectrum on your left side. Yeah,
this is a spectrum on the left side. You take a bite, okay, you put it out from here. First thing I put is a PDS, right?
Okay.
Then you take it out from here. You put a knot and put a fiber wire on that knot from the center of the cannula. You pull it out.
That we understood, because this is the railroading of your fiber wire suture.
Yeah.
But problem is that if you
then what you were asking? Tell me.
No, problem is that if you use the spectrum, you cannot go very end at the end of your graft. Is it end of your stump? Is it true, or it is you can do this way?
No, you can do up to the. Why you need to go to the end of the stump? You need to go up to the
tibia. We understood, but most of the time we are taking the bite portal on the back side, posteromedial portal, taking the bite by your scorpion or whatever device we use for the rotator cuff.
But then you are putting the multiple knots.
No, you can use the multiple knots. Those who are using the multiple knots, they are using like this, no?
Right.
Because you have to hold the fragment.
Right. But you are pressing the fragment because you are going above the fragment.
Understood. Okay? Understood.
And as you can, if you can make two tunnels, then you even don't have to use the button.
Understood. If you make two tunnels, just you tie on the front of the bone.
Right. Just you tie in the front of the bone.
No, this is a good technique, but I have never used this. Next time I will use one.
Yeah, you use it. This is very good technique, and it's easy to do it, and there is not much of a problem. And I have not seen.
This is probably easier technique rather than struggling with the backside.
Yeah, absolutely. But as I told you, if it is a chronic injury, 3-4 months old injury, then I will have to take a posterior approach. And
in a chronic case, you have to take it. Otherwise, you cannot go to the downstairs. No.
Yeah, absolutely.
So,
okay.
Nishith sir,
Obey the question. Yeah, Obey.
How easy or difficult it is to do a PCL avulsion from to anterior portals when the ACL is intact?
Not much. This guy has an ACL intact.
Mm-hmm. So
you can create the window very nicely. But see, a lot of people, they do a PCL reconstruction in between the PCL and the medial, posterior horn of the medial meniscus, right? Yeah. That is one of the approach which is very, very popular, right?
Yes.
For me, that approach is not existent for me, because I have found out it's very difficult to negotiate my scope through that portal. So my portal is always between the ACL and the PCL. If ACL is not there for reconstruction, I am very happy. So if I have ACL PCL injury both, I am very happy, because that gives me a lot of leeway to put my jig and everything. But if the PCL injury, the first thing that I do is I take out the tissue between the ACL and PCL, and then I put my tissue elevator, go backwards, and I spend time to elevate the tissue from the back of the joint, and that makes the life easy.
Nishith bhai, does making a posterior medial portal, maybe just putting a probe through it, help you in manipulating the sutures over the fragment and also reducing the fragment more anatomically?
But the thing is that why you want to do that? Because when you are pulling out the wire, okay, the wire is above the fragment, and you are pulling it down, and if the fragment is pressed, because you are going to tie it so tightly in the front, the fragment is already going to go back to his tibia, and even if I tell you very honestly, I have seen some commented fragment where you see when they come after 1 month, they are lying up, and after 6 or 7 months, they are all incorporated, and you do not see the commented fragments.
Okay.
So do that.
More biological. We should not manipulate too much.
Yeah.
Just put sutures, then pull it down, and it would heal there itself.
Yeah, it will heal there. Absolutely.
Okay.
Right.
I have a question.
But when you take a bite, sir, it has to be more close, more down, if as much as possible you want.
Yes. That is why I want to use the IITV.
Okay.
That is why I want to IITV, and then I put this pin.
Okay, sir.
So I know
yes, you had a question?
Yeah. So any of us do make a posterior lateral portal for PCL avulsion or PCL reconstruction?
PCL reconstruction, I usually sometimes I take both the portals, posterior medial, posterior lateral.
Sometimes.
Yeah. Especially when there is a ramp lesion or something suspected, then that portal really helps. I'm going to show it.
Yeah.
Okay.
We can go ahead, sir.
Yeah. So IPS, you had given me the reconstruction.
Yeah.
Which I feel that most of us can see on YouTube and everything.
Yes, sir.
What I thought that the experience that I have gathered
your tips,
for many years, I would like to give the tips that how to make the PCL surgery more safe.
Yes, sir.
And how to make it better.
Okay, sir.
Okay. So small things, and I will be happy if somebody asks me the question for this. Okay. So first thing that what we have to do is that position. Okay. We know that the artery is very near to our approach of the PCL. So this is one position that I prefer to do, because now I'm getting old and I get backache if I do a hanging position. So this is easy on spine. But if you have a grade 3 laxity, then the subluxation is going to come very near to your artery. And at that time, what I do is I prefer to have the hanging limb position. So other limb we tie, and we see that this is very easy. So there is no constriction of blood vessels or anything here, and the we do not even move the position of the table once it is fixed. But this is what the hanging position is, and I'm sure that there are a lot of people who use this position. And but this is a position which is in very rare for me. Most of the time I do in lateral position with the lateral support, as you seen here. And this is what my position is for most of my PCL reconstruction surgery. This is my trolley is, and this is what I feel is that we must have the height in the operation theater, where you can give the height of around 7 to 8 feet totally, or around 4 to 5 feet above the table. And if you do this, and if you do, use 3-liter bottles, then you do not have any fancy pump. I do have this pump, but I do not know when I have used it last. As far as my ligament reconstruction knee is, so I think I will have to run it, because it has been lying idle for many days. Even now in shoulder, we do not use this pump. Usually we used to use it before, but now, do you use IPS or sermon in any of this surgery?
Not exactly, sir, unless and until the patient is too fat and you don't want to put a tourniquet, then you use pump. Otherwise, usually, for knee, no, but for shoulders, yeah, we are still in the subacromial space. Right. We have to use pumps.
One of the problems that
knee surgery, you are not at all using the pump.
Yeah. I also, what even in shoulder, I usually I do not use the pump. Now the disappearing knife, and this is one of the dreaded complications that I think everybody must have faced. If you are lucky, then you will be able to take it out. But if the people have been unlucky and they have spent hours to find out this IITV and other things. So what I do is that my camera bag is specially made, and that camera bag has this sticking thing. You can, of course, you can tie even a thread or something. But this is what the thing is, and because especially when you take a posteromedial or posterolateral, you try to insert the knife very much inside, and I don't want knife to remain inside and do this. So this is what I usually do this when I do a PCL surgery. The normal anteromedial portal that you take is not sufficient, especially where the ACL anteromedial portal is low down, because we want to go and hit the lateral femoral condyle at a proper place. But here you need to take a high anteromedial portal with a 18 gauge spinal needle. So this is what the anteromedial portal is, but the anteromedial portal is high, and that allows me to I used to do without any posterior portals before, and that is why I used to take a high anteromedial portal. But nowadays I do take posteromedial, and if required posterior portal. So now this is not that much, but high anteromedial portal always helps for better visualization of the popliteal area of the joint. And one has to be very careful when you are taking an anteromedial portal. It should be as nearer to the midline possible. It means just by the side of the popliteus, bone patella tendon. On the medial side, you should not nick the patella tendon, but just by the side, so that if you are too much medial, then you are going to scuff the articular cartilage when you are doing, especially the inside out portal or inside out femoral tunnel. You are likely to scuff the articular cartilage. So when you do this, you have to be very careful and at least see 2-3 times that your spinal needle is a proper position. It will be able to make a good femoral tunnel, so that you don't want to do this dreaded complication of articular cartilage damage. Posteromedial and posterolateral portal. The posteromedial portal, you can lower down the lights of the theater. You can see that you can see the glow, and you can insert an 18 gauge spinal needle inside, and of course your scope is through the window between the ACL and PCL, and you are able to see this just behind the middle femoral condyle and the medial meniscus, as you can see here. And then with a switching stick, you can create a lateral portal also. You put the switching stick through the cannula on from the medial side, and you go on the lateral side, and you can make both the portals. And from one portal you can use arthroscope, from other portal you can do a shaver, and this helps in taking away the tissue from the behind the tibia way down, so that you can see a very nice PCL attachment, and you could do a better PCL reconstruction surgery. There is no harm in taking a posteromedial or posterolateral, especially the posteromedial safety incision, and putting your finger through that on the back of the tibia, and then do a tunnel. And this is usually even in today in a very small children, I do this so that, because there I do not know how far it is the artery is lying or the nerve is lying, and that is why there is no harm in doing in adult. I have seen Deepak Chaudhary doing this for years together before he has started doing it all arthroscopic PCL reconstruction. So please take safety incision whenever it is required, wherever you are not confident, and especially a chronic laxity where you have posterior capsular contracture along with it, then this is the very safe approach. Graft, you can use a quadriceps tendon graft. CQT is becoming very popular because you can even harvest with a small tendon. Of course, the hamstring with doing we are doing augmentation. So with Semity and Gracilis, you can do 7 or 8 millimeter, 3-strand 7 to 8 millimeter, or total of 5-strand. You will get at least 90 to 100 millimeter length if you do a 5-strand Semity and Gracilis together, and that is sufficient to do augmentation of PCL. You can do a double bundle, one with CQT, one with Gracilis, and in few patients when the revision PCL is required, I have taken a bone patella bone with around 50 millimeter long bone plug of tibia, and this has worked very well. This was before the advent of because as we understand the femoral footprint is very large. We want to do a double bundle, or we want to augment, and nowadays we do not remove any of the much fibers, and do augmentation surgery, because we want more collagen in the tunnel and for the better graft uptake. The peroneus longus is becoming very popular, and now we have long-term result, not only when the Indian patient, but also people like Bancha, who has shown that this is a very good graft because it is easy to harvest. The thickness is very good. If you do a three-strand peroneus longus, you will get 90 or 100 millimeter graft, which is sufficient. So length is very good, thickness is very good, and 5 years result have shown no long-term comorbidity. Of course, my experience with this graft is not that great, but I have started using it, and I have not seen any complication in my patients. What about others' experience about this graft?
I've not used it, sir. I don't use peroneus. I'm not sure. I think Samanta would have.
All my PCLs now, sir. I think it is a fantastic graft for PCL.
Yes.
Oh, you use it, Bhupesh. Okay.
We are worried about hamstring not being enough for PCL always. But now, last 2 years, I've been, at least last 1.5 years, 2 years, I've been using this. But one caution, although touched, I have not had this complication. One of my friend told that he had a transient common peroneal nerve injury after harvest.
Yes.
So it should not be very aggressive in pushing the harvester all the way up to the fibula head.
Absolutely, and you know, you have to, as you see that you have to put the blunt scissors, long scissors, up to the almost where your this. And usually what I do is that I measure from outside that how much is going to go up, you know, so that, you know, I know that more than that I don't want to push. I would
Nishith bhai, this is an excellent graft. And basically this has got no complication at all. People thought of probably he will lose the evators and power and everything, probably going to injure the common peroneal nerve. But luckily, touchwood, it never happened to, like that's like Bhupesh.
And even people, they don't know to take the stitches also.
No, it is primary. It was told that peroneus longus stump has to be stitched with the peroneus brevis. It's not needed at all.
No, it is not needed at all. This was my initial, so I have shown that I am stitching, you know.
No. Lengthwise and breadth-wise, both ways, this is fantastic. Both for the primary and secondary, all your revision cases.
Yeah, revision cases, this is a fantastic graph. There is no
fantastic one.
But still, I will prefer bone patella bone.
Yeah, that's it. That's the other way, because unless you have the option, probably will go like this.
Everybody is afraid of kiloton, and I do not understand why they are always promoting that it should be made at a 45 degree. Usually, I do not make it 45 degree. I put my PCL jig and I do at around 60 degree, and I feel that makes the tunnel more obtuse, and my graft passage is. But before I pass the graft, I always use a shaver and the dilator. And if I have taken the postmillennial portal, I will always see the dilator is coming inside the joint, and then I will put the wire loop to pass to the graft. So this is what very important instrument in my armamentarium as the tissue elevator for PCL reconstruction. And I remove all the tissue, but I do not think that RF is required for this kind of surgery. What is the opinion of others about RF?
No, RF is not at all required for any knee surgery in my place.
Yeah. Yes.
Sir, in this I have seen that you have used a BTB graft, this X-ray. So how difficult is it to pass a BTB graft? Because hamstring is okay and CQT we do it. It is easier to pass around.
That is what I
BTB is difficult to pass, isn't it?
Yeah, I know. See, the thing is BTB, 2-3 things what I have marked is, one thing is that I will make tunnel 1 millimeter larger.
Okay.
Second thing, that the BTB bone is not more than 20 millimeter.
Okay, so that's a smaller plug.
And it will have. I will make it. Usually, my assistant will make the graft like everybody else. In BTB bone patella bone in PCL, I will make the graft by myself, and I will make it absolutely a triangle graft on the top. I will make
like
it
a bullet shape.
Like bullet shape, you know, and not more than 20 millimeter, because if you have a larger graft, then it doesn't. The turning is very difficult, because it has to come inside the intercondylar notch to pass through the femoral tunnel, you know. If it doesn't come in the intercondylar notch, you will not be able to turn it, and the graft is likely to break. So I even if it's 18 millimeter, I am very happy, because most of the time I am using unless the patient doesn't know about, now I am using either a metal interferential screw or a bio screw, and I do aperture fixation.
So conventionally we have been pulling the graft from the tibia up and putting into the femur.
Yeah.
I mean, I want panel to just let me know. There are some surgeons who are actually putting it from the femur and then pulling it down through the tibia.
Yeah. There are people.
So Samanta, Bhupesh, Abhijit.
I always go from the tibia to the femur.
Yeah, we do it from tibia to femur. But Bhupesh, any idea? Have you seen the technique?
Yeah, sir. Last 2 cases I have done from femur to tibia.
And it's easy?
I wonder why I didn't do it for so many years, sir.
That is what my question. Yeah.
No, but the thing is that what is the length of your okay? So there is no difficulty.
Whatever the length, first
whatever
you fix the femur, and from anteriorly you pass the graft posteriorly. It is very easy. The killer turn is always going to be there. It is going to be a spin on the graft. But passage is never a problem. You don't have to put a Wissinger rod and keep pulling. Last 2 cases I have done fixation of femur first and pulling it out. It is very, very easy.
Fantastic. We'll try next time, you know. Good. Good.
Yeah, I think just for seeing the time. Tejas has a question. Okay, Tejas,
you can unmute.
Sir, as I am a beginner of the arthroscopy and regularly doing ACL, but PCL is although a rare cases and coming also less number than the ACL. So how can one progress from ACL to PCL, and how can one learn the art of doing PCL as
No, that is a very difficult question, Tejas. Skill is you have to acquire itself. Going to the human specimen lab and seeing somebody and taking, whenever you start doing your PCLs, you take one senior guy who has already, because PCL you cannot should not go, because if you misfire, it is misfire with the limb.
And Tejas, if you are a traveling surgeon, do not do PCL anywhere.
Okay. So PCL, if you misfire, this is misfiring with the limb. So it has to be with somebody's guidance. One, you are super confident, and I will tell the juniors, which is no shame to take the safety incision, because if you just put the incision and if your finger is like this way from the medial side, just the back of the tibia, you can sleep properly and the patient can sleep properly.
Absolutely. And don't be shy of using IITV in the initial stages, you know.
And
use IITV.
What do you say about
when you do an ACL, Tejas, in your routine cases, try to make a posterior medial portal.
Yes, sir. Just now I have started
the thing, and start putting scope through the posterior medial portal to see behind. You will become much more comfortable looking at the anatomy from behind. And then whenever you are doing an original case for a PCL, it will be much easier for you. So for ACL, make it a habit to make a posterior medial, maybe just by a needle, fiddle around, and then a small portal with single rod, and then shift it, see from behind, then go back and do your ACL the way you are doing it. But try to see more back of the knee, makes you more comfortable.
Yes, sir. Sir,
Nishith, sir, can I just...
Sorry. Bhupesh, go ahead, Bhupesh.
No, sir, about the fixing in the femur and pulling it down, retrospectively, what I understood is always our soft tissue grafts, in the tibia, the size of the graft is smaller. When we fold it into two, all our grafts, when we double it, the femur side is always thicker. That is why when the femoral side comes through the tibia, we have suffered. But once we put the thicker side into the femur first, from the anterior portals, pulling the smaller whip stitch, the end of the graft into the tibia is always easy. That is what I have found.
And usually 1 millimeter more doesn't make any difference in the long-term outcome, but it makes your life more easy. I think so.
I think that is a great point from Nishith Bhai, that if you're like in the ACL, we always tell match to match tunnel. But if you in the PCL, even if you make just 1 millimeter bigger tunnel in the femur and tibia, the life is not going to be that harmful.
Absolutely. Because most of us are doing extracortical fixation. Doesn't matter much. You know?
Abhijit has a question. Yeah, Abhijit, go ahead.
Nishith sir, for the audience sake, what are the precautions one should take while making the tibial tunnel?
All precautions.
All precautions. I mean, the first thing that as Oberoi said or something, either you put the posteromedial scope from the posteromedial portal 30 degree, or if you have 70 degree, then you can go from between the ACL and PCL, because 70 degree will give you the same vision what you can do 30 degree from the posteromedial portal, you know. So that, and I say that if you are in doubt, if you are not confident, just put this finger, you know, दो सेंटीमीटर का एक incision बनाओ posteromedial area पर, and you just put your finger, and then you make a tunnel from the front on in tibia, and that is and you will be able to palpate even the jig coming in, and you will be able to see the jig very nicely, that it is sitting properly in the champagne place
drop,
and champagne drop place, and then you'll be able to do a very nice PCL reconstruction. PCL.
Abhijit, just I want to give one comment for the juniors. If you are not extremely experienced like Nishith Bhai, you should not do somebody should not be doing PCL only with two portals from the front.
Yeah, absolutely.
This is for the very experienced guys.
Yes. No, even I do, because I have also changed. I do now take posteromedial portal. I used to do it because I started like doing that, but nowadays I don't do it. I do because I feel it's a very safe. It is more anatomical. It shows me very nicely, and I can remove the tissue. I can do many things which probably I was missing, you know. So I have changed then.
So okay, I think this is why we can go ahead.
Okay, so this is the turn. The femoral tunnel, as we understand that you can make it inside out or outside in. Okay, and usually we try to do anterolateral bundle. So you put this at around 5 to 6 millimeter behind the articular marginal junction, bone junction. But you, as you I said you that don't go from these, because otherwise you are going to scuff the articular cartilage, because your graft is going to be at least 8 to 9 millimeter, and you are going to scuff. So be slightly away from the medial femoral condyle and see that you are at the proper place. And then what I do is I just tap the drill tip passing pin and then use my jig, so that the jig does, or you can do a little bit of pre notch and do so that it goes to the proper place. And of course, if you are doing outside in, then there is no problem of scuffing the articular cartilage. And for outside in also, I put a bio screw from outside in nowadays, so, and that bio screw I see at the mouth of the tunnel, and then I stop. So even you can do a bio screw from outside in, and it is given also the same good result. So both the outside in and inside out, but both you should be able to do it for a PCL reconstruction. And you do not, if you are careful, then you do not get this ballooning of the joint, or there is a neurovascular problem later on. So this is what the outside in, and the jig gives you exact idea that how much you are away from the bone cartilage junction, and that is what it makes it very precise. So if you want to use this jig, there is not a problem. And this is what we know that endo button and the suture disc on the tibia. Okay, so and this is what the tibial tunnel is, that you have the tissue elevator come wire catcher, and you can see that it will not let the pin go posteriorly, because the posteriorly you have neurovascular bundles and everything. So this is what the very important instrument is, the tissue elevator come catcher. And if you do not have this instrument, you should buy it, and you should not do a PCL reconstruction surgery without the instrument. If you are novice, or even I will not do, because the vascular, you can see this is the if the pin is at the proper place, then it is the vascular, the blood vessels are hardly 1 or 1.5 millimeter, even with the sorry, one around 1 centimeter with a good distension. It is not, the leeway is not very much. So you should be very careful when you're removing the vehicle. And then once this is done, then what I do is I have a 24 gauge or 22 gauge wire that is passed, and it is you can see that now already have created a femoral tunnel. What you need is you can use this, or nowadays I like to do, what I like to do is I take this spade tip passing pin of the Arthrex, and that it is a wonderful thing. It has a notch on the back, so you just put this and you pull it out. Of course, the assistant is holding the tibial end very nicely, or we also just put a artery forceps so that it doesn't come out on the femoral side. Femoral fixation, most of the time, this is also very good, but I do a bio or titanium interference screw, because I feel it gives me aperture fixation. There is no bungee effect, minimal synovial bathing, and my fixation is more anatomical, because the healing is aperture. We all know that. So I think, but there is nothing wrong if you are using a cortical fixation. And but it is a technically demanding, and if you do not have a notcher or something, and if you put a larger size screw, it can damage the graft, which most of the time you will be able to avoid with the endo button or similar devices. On the tibia, I usually like to use the suture disc because it gives me a great feeling of tightness. And with this suture, this is a twister, I can tighten it and I can check it. It has a spring device, so you can check that how much tight you have become. And of course, that the assistant is holding the tibia anteriorly, and I what I do is I do a step of test when I'm doing this, so I exactly know that how much anteriorly I have to make it, and how much tight I have to make this. And believe me that I have never used fiber wire. I always use either Ethibond number 2 or Ethibond number 5 for all my PCL reconstruction and graft preparation. So I don't think that we need to use any fiber wire, or it has given me added advantage of fiber wire. Yes, I have switched over to fiber wire for pull-out sutures when I do avulsion, but not for my PCL reconstruction surgery. And you can see the tunnel very nicely here. Of course, the postoperatively before the table, it is moved out of the table. You have to put your pulse oximeter, and till the time anesthetist phones me that the pulse is fine, the patient is not moved out of the theater after the PCL reconstruction surgery. And this is what this I have ready made available. I have bring it over here. This is what the PCL pad is. You can put it in a normal brace, or you can make it nice brace also. And of course, my rehabilitation is very slow. I'm very aggressive in ACL, but not here. So this PCL brace remains day and night for 6 weeks for most of the patients. Of course, they remove the brace every day as they go on the prone position. They do active and passive, both prone knee bending, but other all the things when they are in supine position, the brace is a part of their body for around 4 to 6 weeks. And if I have do a multiple ligament surgery, then that remains a part of the body at night for a more 4 weeks. So around for 2.5 to 3 months, this PCL brace protects them for most of my patients during night time after 6 weeks. If it's an isolated injury, I allow full weight bearing from the next day or to the comfort of the patient. Passive knee bending from day for 3 to day 10, and no squatting or cross-legged sitting for 3 months. But I think most of my patients, they are so comfortable if it's the isolated PCL injury, that usually by 2.5 months they start sitting on the ground, and they few of them, they start driving the car and everything within 6 to 8 weeks if their knee flexion is very good. The post-op rehabilitation long term is that the hip exercises and the core stability, and then the strengthening phase comes. And I don't want very active hamstring is okay by the patient, but no passive hamstring or passive strengthening exercises, because it is it is going to pull the PCL that we have put. And jogging and patients can start after 2.5 to 3 months. And cycling, I love it, and I think that a lot of patients, they are able to do cycling very well after 3 months. And of course, the sports specific exercises. Complications are hallmark of any surgery, and graft on the floor, we can discuss for life. The graft cut through by interferential or bio screws can happen, and that is why I use a notcher all the time. And usually in young patient, I will take 1 millimeter less screw as compared to graft diameter. And of course, neural injury is not that common, but that can occur, and we have to be careful about it. Graft on the floor is always, it has happened with anybody, and there are various things you can do. But the most dreaded complication is vascular injury, because as I showed you, there is a very small leeway between the, and if in the long term either there is a flexion deformity, means there is a tissue in the intercollar notch, and few patients, they do not get more than 90-degree flexion. And I wait for around 2.5 to 3 months, and if it's a soft, is this soft, then I do manipulation and anesthesia after 2.5 to 3 months, and I have not seen any graft rupture or graft failure. If the patient comes after 4 or 5 months with this kind of problem, then I will ask them to go for arthroscopy and aerolysis. At that time, I don't want to do any manipulation. Osteonecrosis of the middle femoral condyle, we have always read about it, but I have not seen in my life, and I don't know any of the faculty has seen in other people like IPS or Swarnendu who was doing this surgery have seen this or not. Have you seen?
No. Osteonecrosis I have not seen, but the thing is that probably you have been told that whenever you do the tunnel, it should be probably from the middle of your medial epicondyle and also the superior-medial corner of the patella. If you do like that, then probably you are not going to face the osteonecrosis. If you are very close to the medial epicondyle, then you are going to face the because your drill is most likely it is like 9 millimeter.
Right. So this is what, and of course I have not seen fracture, but people have reported that there is a fracture. I don't know how. But knee stiffness is one of the, and DVT also we have not seen much. Either one or two patients. But do you give any Disprin or Ecosprin post-operatively?
No. Because thing is that whenever I do the PCL or PCL, whatever this anti-DVT prophylaxis, we give injectable for 1 or 2 to 3 days. But
do you every patient?
Every patient.
IPS?
Gets rivaroxaban for 3 to 6 weeks.
Oh, really? IPS?
No, sir. I think for us mainly ankle pump exercises.
Yeah, absolutely. So for me also, that is enough.
But again, DVT is something which is real. It is there for sure, and there are litigations around DVT as well.
Yes,
but there are no clear-cut guidelines. So I mean, I think surgeon is free either to use mechanical devices or pharmaceutical devices.
Right.
Because of the litigation, I don't know how much your science is behind that. But if you but to be on the safer side, I always give the rivaroxaban for 3 weeks.
Okay.
So there are a couple of questions on the chat box, sir.
Yes.
Vinay has said, sir, Vinay Bangere. So what is the angle of the guide which you set for outside in for the femur? So when you put a zig from outside in for the femoral, what is the angle of the
around it comes between 15 to 20 millimeter. But the thing is that usually my take is that medial border of the patella and medial epicondyle,
somewhere in between,
and in between I want to put.
But
so according to that, I adjust my jig, and because if I am doing outside in, then I can see that how much I'm away from the bone articular cartilage junction inside.
No, that is true, but they was asking just about this is the sagittal plane alignment, sir.
Yeah,
the angle where you fix it's a variable angle.
Varies between I think 15 to 20 millimeter. Usually it varies.
No, he is asking probably the question from the sagittal plane. Sagittal plane, it is around 45
40 degree. Yeah,
45 degree.
It is 45 degree. Okay.
Yeah, sure.
Another question is, and to all the panel actually, from Dr. Naveen, he says, any experience of a tibial inlay technique to avoid the killer turn? So is somebody doing a tibial inlay?
I have done in one patient tibial inlay.
Okay, sir.
That patient had a only 90 degree of knee bending because of his previous problems.
Okay.
So and that was like a fix, and he had a PCL injury. So what we did was that we took a bone patella bone graft.
Yes, sir.
Fix it in the femur first. Bring it, and then we did I can show you that if somebody is interested. But that is the only patient that are done.
So you turned the patient around and did a mini arthrotomy and did
that we did.
Okay.
Yeah. But otherwise, I do not have any experience of inlet.
Another one question I want to pass to the juniors, that whenever you do the PCL, please take a new beath pin. Okay. Second thing is that before reaming, whatever reamer you select, see that the beath pin and the reamer are going very smoothly. Because if you use a bent beath pin, or sometimes you use a pin if the reamer is not very clean, sometimes with the reamer that beath pin can advance. So these are the very two common mistakes, and take it as a print in your brain that it has to be a new beath pin, and check that your reamer is very clean and it is passing very smoothly.
And whenever you are stuck, don't push.
Don't push.
Take it out. As Samanta has said, that you check everything again, but don't push. See, in LCL we have a habit that we push the things. If it is not coming out, we are pushing it, so ACL becomes very safe. But PCL, do not push anything, especially when you are creating a tunnel in the tibia.
another tip is there, and I think I can just share it with all, because somebody has written, to avoid the killer issue, if you are passing the graft with knee in full extension, it's a very, very easy pass. So anybody who has passed the graft in full extension and found it easy, maybe Bhupesh, Samanta, can comment.
Problem is that
Tejas.
it might be easy in extension. Problem is that we want to see with the scope. In the extension, you cannot see the graft is passing usually.
Absolutely.
But it will be a blind pass.
It will be a blind pass, because you know that if you are doing the tunnel from inside out, or whatever tunnel you are doing in the femur, we want to see the mark, whatever the blue mark we are given to the graft, so that we know that this much graft has gone in. So usually done in flexion. And if you use your Wissinger rod as the pulley, whatever pulley you use, it is not the problem. The trick is that you always make a 1 millimeter extra tunnel, then you.
And you know,
that I think Bhupesh was telling that if you pass the... Yes, Nishith bhai, go ahead.
Sorry.
Nishith bhai, please. No, boliye. You boliye, sir. Sir, aap boliye.
So many times when the graft is not passing on the crenal turn, what I do is that I bring the scope out in the intercollar notch. I'm not and then you give a pumping flexion extension, and the assistant is putting the graft, and the graft comes out on the femoral side easily when you are not able to do in the 90-degree flexion. But usually this is so I understand that when you do extension, the graft usually pass easily, but most of the time when you do good flexion and when you do a 1 millimeter more tunnel, the graft passage is not a very difficult thing.
Another useful thing is to put a Wissinger rod in posterior medial portal and use it as a lever.
Yes, that I was telling, because that is the pulley.
Yes.
Even you can put your probe in the intercollar notch near the base of the PCL in the front, and you pull it up, and it gradually, and the assistant gives you pull, and usually the graft will come.
All these problems are negated if we fix the femur first and pull it down, sir.
Absolutely.
We'll try it next time.
We'll try.
I have one question to all panelists, sir, because I graduated from outside in jig for femur. And then now I started doing inside out. But inside out, I'm always worried that I might be too close to the subchondral bone and the MFC. Any tips or any accessory portals that you make in the front to do a good inside out?
So I think Dr. Nishith used to do inside out before. I saw him.
So I usually take a accessory medial portal.
And where is this portal, sir?
This is usually it is just below the upper medial portal, slightly more on the medial side, and you take a spinal needle, which I will be able to show you the portal somewhere. So, and that portal is and you will be able to see this coming in very nicely on the middle femoral condyle. And there should not be, see if you see here my pin, okay, this is through the accessory medial portal.
Will it come very close to the patellar tendon, sir?
No,
or
it doesn't come to the close. That is what you want, that you do not want to go, because the more you go on the medial side away from the patellar tendon,
more is the chance of scuffing.
Yeah, the more
I'm worried that the excuse me, sir, the tunnel that you are making is very close to the subchondral bone of the medial femoral condyle.
Yes.
So if we come closer, won't we go more deeper? Is what I was thinking.
So the theory is
more medially, we are more towards the subchondral bone of the medial femoral condyle.
So for the anterior lateral portal,
see, this is what
this
portal is.
Yeah.
Can you see this?
Okay.
Yes.
This is the
perfect.
portal.
Perfect. Sir, another question is how do you evaluate how deep you have put the screw on the tibia? I mean, do you want to put it right till the posterior tibial cortex, or you just fix it?
So now it's first thing that usually I do not use bio screw. But if I am going to use bio screw, then I 100% I'm going to put my scope in the posterior medial portal. Put the wire and I am going to see that the screw comes.
Tip of the screw is
the
there.
screw comes.
Perfect.
That is 100%. But most of the time, I like to use the switcher disc. Makes it economical, and it gives me solid fixation. That is what I love to do.
Perfect.
Yes,
Vishal, you have a question?
There's one more trick for that, sir. So you measure your tibial tunnel length and mark take the screw on the screwdriver and mark that length with a steri strip and push only that much inside, so you don't have the fear of the screw falling behind or being short of the aperture, and that also helps.
Yeah, technically यार अभी बहुत ब्रेन नहीं चला सकते हम इतना सारा. बराबर है.
That is a good trick. That is a good trick.
Very good trick. Very good trick. कोई सवाल नहीं है. So I once again I would like to repeat the same thing. Do not do arthroscopic PCL reconstruction if the vascular surgeon is not available within 1 or 2 hours of your clinic. Okay, and if you are traveling arthroscopies, do not do it. And because not only that, if you have done a superb surgery, the follow-up is a must, because you are the only person who are able to do this follow-up, and you will be able to advise the patient for proper rehab. ACL is forgiving. Even if you're not seeing the ACL reconstruction patient again, the patient is not going to complain. But the PCL, if you do not see the patient again, the patient is going to come back after 6 months, 8 months, or 9 months with a problem. And then, because as IPS said, that now we have to be very careful about medical legal problem. And if you do not have proper instrumentation, it is not, this is not a surgery you should do. You must have proper instrumentation. And even the company guy brings the instruments, please check the instruments, because we have had a very big very bad things with the blunt pins and everything, and nothing but like 8mm is not available, and there are a lot of problems we all know, because we do not want vascular injury. You do not want such things. This is my own patient where I did the injury and amputation was done. So I don't want this. I cannot forgive myself for this patient, and this is what I don't want. There are some interesting patients. This is a young boy who came after 6 months after his intramedullary nailing of the femur with a non-union. And this was his range of movement 30 to 70, and posterior capsular contracture. Extension was not possible. I could not do. There was a consistent posterior sag. So first thing I did was I give him a double pill traction in the ward. So pull the tibia in the front. Okay, and this is the system that a patient can take home. So he took it home. The same thing. You can hang this. Gradually you increase the anterior tibia weight, and this will pull the. But unfortunately, even after 3 months, this was his intermediary nail of the which had a non-union. And this was the pin that we put, and we could measure that this, you can see that posterior subluxation of tibia gradually it was coming up. But still after 3 months, his range of movement was 30 to 90 of still there was a posterior capsular tightness. Of course there was no, but the great thing happened was that the femurs united. So at that time, this was in 2010. So at that time, my friend was doing a lot of Irizarov, and he told me that we can go on gradually stretching this. So what we did was we did a plaster wedging technique with the external fixator in this patient, and you can see that gradually we did it. And almost after 1 month, when he had everything corrected, we did a PCL reconstruction by taking graft from the opposite side. I never wanted to do from the same side, and this is what he has sent me before, say around 1 year. That this was his, this is in 2014. Now it is almost 10 years now. This was his range of movement. Very happy guy after this double pin traction, posterior wedging, and this was a surgery. And believe me, this is not uncommon. Many of the chronic patients, when they come to you, you will be not be able to bring them forwards to the normal level if you do a step of test. And you, if you do the surgery or PCL reconstruction in such patient, it is going to fail and the patient is going to never forgive you. So your capsule has to be loose before you do a PCL reconstruction in old cases. This is one of my patient. I have done around 6-7 ligament reconstruction. He goes on falling again and again. So this was his. He came with a posterolateral instability along with the new ACL, and this was his PCL that I have already done once. And this is what is. You can see the tunnel and everything. But now he had a medial compartment arthritis. So what we do was, I took a bone patella bone and of course the open wedge osteotomy, and we did a reconstruction with the osteotomy. And you can see this, and this is what this has made the. You should be, means it was surprising for me. The moment you do this open wedge, the posterolateral corner becomes so tight and patients are very happy. And this is what I love to do is PCL reconstruction in children. This is my youngest patient and probably the youngest patient having underwent PCL reconstruction in the world. And this is what she was 3 years in 2008, and I had to take a mother's autograft, mother's allograft, mother's CMT to do surgery. This was when she was 3.5 years old. I did a PCL reconstruction. You can see the PCL tunnel, and I deliberately used the bigger implants so that she has to come for removal and I will get a follow-up. And this is what the same girl is. This is after 7 years. This is 2019, and now she has increased by 2 inches. There is no limb length deformity. She has a full range of movement, and this is what. So if you do a good PCL reconstruction, and if believe me that this is the transphysial tunnel. Okay, this is extraphysial tunnel. The tibial tunnel is extraphysial, but this is a transphysial tunnel in a 3 years old with a 7 millimeter graft. They said that if you have more than 20% of the graft, then it is likely to fuse the fuse the epiphysis, which has not happened here. I don't know how I escaped, but this is what actually the result is. And this girl has a full range of movement. The mother is no problem. And I have been lucky that this is my first PCL reconstruction in 1994 with a bone patella bone graft, because that is the only graft I knew at that time for a reconstruction of the ligament. And you can see a big posteromedial incision on the safety incision for my graft. And he came after 25 years with little bit of arthritic changes, pain, but with full range of movement. And I am grateful to you all, my friend IPS and Samanta, to give me the chance to be with you. I'm grateful to my patients, and I love Indian Arthroscopy Society because it has become such a dynamic body, with guidance of these two people, and of course worker like Sandeep Biraris and many of others. I'm very proud that I'm a part of the organization, and I have been able to thank you, IPS, for giving me this chance to be with you and to deliver something, my thoughts on the that I love.
Yes, Nishith bhai, just answer your screen. Yeah, done. So this was an excellent
this is the PCL pad 25 that I keep ready. Okay, this is the PCL pad.
Yeah.
Okay, yeah, right.
So there is one question from Tejas who is asking, what is the safety incision that you showed?
Tejas, what you do is that you pass the you see you palpate the posterior femur condyle, okay, and the tibia, and you go 2/3 above the if you have 3 centimeter length of the then what you do is the 2 centimeter in the femur and 1 centimeter in the tibia. Okay, and then what you do is that you take you just cut the skin, and of course you cut the fascia and everything, and then just take either a blunt osteotome, but blunt, okay, and just keep to the tibia posterior part, and just erase the capsule or erase the tissues from the back of the tibia, and then you will be able to put your finger in the middle part of the tibia on the both condyles where the PCL is.
Basically, Tejas, because if you give the incision just at the posterior medial, but just beyond at the margin of the femur, you just have to incise the capsule and you have to put your finger there, so that you are absolutely on the back and middle of your tibia, so that where your guide wire is going, bead pin is going to be intending to come out, your finger should palpate first.
Yes.
So that is the safety incision. Understood?
Yes, sir. Yes, sir. Yes, sir.
Okay. Okay. So I think we have got the experience from the one of the most experienced guy in doing the PCL reconstruction in our country, and he is. I told you in the beginning that he is very passionate, and once he will start discussing about the PCL, he will be emotional too. So this is you have got something who is speaking from the heart for last 25-30 years of experience in the arthroscopy. So it is a nice and excellent exposition, and you are really an excellent teacher in our country. We are really honored to have you in the IAS.
Samanta, it is a pleasure, and what work you and IPS are doing is fantastic, boss.
This is because
I'm sure the Karthik, Sandeep, everybody will agree with me, right?
Yes.
No, the backbone is like Sandeep and the
no,
whole.
Sandeep, you will be surprised that if you have any problem in the computer, now I call him, you know. I think Karthik has given us so nice. Karthik, I would love to have your those pictures, you know.
Yes, sir. Sure.
Because anything we can make.
Fantastic to see a 3.5-year-old child, you know.
Oh, I got a three patients with mother's graft, all prepubescent, all have become adult now, and my fortunate thing was that all three are from Ahmedabad. So wherever I call them, they come. But now they have become adult, except this girl is now 16. So, but her growth is almost over. So
I think today we had real great discussion. It was not like the one way where Nishith Bhai was talking. We are taking too many questions in between the talk, and also you have clarified. Like, we are really proud to have.
I have learned so much today. You know, like retrograde passing. Now we'll definitely try, boss.
Yes. And very nice to have Vishal and Abhijit, because they are
this becomes an outside internal, right?
Yes.
You have
to outside internal is for you.
It can be inside out also, sir. I did in my last 2 cases inside out tunnel.
So
and flipped it with the endo button from the front.
Okay.
And then a loop from the tibia comes anteriorly. Through the loop you pull the graft.
Okay.
But we can do it outside in also. Outside in, fix the femur first.
Yeah.
But first you are pulling the graft into the femur from your anterior portal.
Right.
And then from your posterior, from your tibial portals, tibial tunnels loop, pull the rest of the graft back into the tibia.
So you mean to say you pass the graft from the anterior portal,
from the anterior,
and then pull to both the tunnels.
From the anterior portal first into the femur.
Yeah.
Like how we pass your ACL.
Yeah.
Fix the from the portal into the femur. Fix the femur either with your button or screw.
So you are talking about anteromedial portal.
Yes, sir. And then pull the graft from a loop which is already kept in the tunnel and the tibia into the tibia.
I understand.
Basically, this is the retrograde one. We are not.
Labrada's technique. Yes.
Yeah.
So Nishith Bhai, we had great discussion. I think we are already been over 2 hours nearly with the PCL.
No.
It is just 6 minutes late. We never knew how this 2 hour passed, because it was really, we are all engrossed in this discussion. I think IPS, you can give,
Thank you very much, sir. I mean, it has been amazing, sir, to listen to you. And your extensive experience has been really very, very good.
Actually, IPS, I tell you very honestly, I have got such a patience with me where presentation for PCL has nothing to, I mean, the presentation is not conventional. I got a young girl who is 26 or 22. Every night she used to tie her dupatta to her calf because she will get so much pain every night. Okay, and this she did it for 6 months. And or when she came to me, I could see the PCL. Oh, I did a reconstruction, and it has been 1 year. This girl has no symptoms.
It's quite amazing. I have heard you so many times.
I cannot believe myself that how this is why this girl had so much of pain in the calf muscles every day night, you know.
I think we need to
and the 200 times aspiration.
Yeah.
I mean, this is something, as you said, that this is something which we need to be aware about. You know, this can happen.
Yeah, absolutely, sir. Yeah. Talking to you has really helped us in understanding that PCL is much more common than we think, and I think we should start clinically examining more often.
You're too
wonderful, sir. I think it was amazing. I must thank you for sparing 2 hours with all of us. Thank you, Abhijit, and thank you, Vishal, for initiating and coordinating the discussions. Thank you, Bhupesh, as always, Dada, Samanta, Tejas, Amol. It has been wonderful talking with Nishith, sir. And thank you, Sandeep, for organizing everything. I think Sandeep has always been so kind to do it. Friends, we have a very, very excellent webinar coming this weekend. It's on 14th of August on Friday at 5 p.m. We have Dr. Miller, Dr. Mark D. Miller, who is head of Department of Sports Medicine, University of Virginia, US. And he's going to talk about revision ACL reconstruction, what is latest. With the advent of ACL coming up in a big way, a lot of surgeons in both A, B, and C grade cities are doing it. I think revision numbers are also increasing. And we must hear Dr. Miller's view about revision ACL reconstruction. Should it be single stage? Should it be 2-stage? We need to meet on Friday, 14th August at 5 p.m. to hear him.